Good afternoon, everyone. Thank you so much for joining us. It appears we have a very large group today, which is wonderful news because we want to touch as many providers as possible. For those of you who don't know me, I'm the state Medicaid director, and we want to make sure that all providers that provide services to our population know of all the flexibilities that have been approved through our partners at CMS. So I'm going to turn it over to Traylor, and he'll walk through some of the flexibilities, and then we'll do a Q&A.
Sure. So normally this would be the time where I take over, but I will be glad to defer to our Commissioner, Carrie Slatton-Hodges, our Commissioner of the Department of Mental Health and Substance Abuse Services, for opening remarks and any guidance she'd like to give.
Thank you, Traylor and Melody, both. It's nice to have so many of you joining today. Of course, this all came on very rapid and sudden for all of us. And so both as our partner state agencies and as providers, there's been a lot of work that had to happen very rapidly in order to try to keep services for those in need going and happening at the same time as keeping ourselves safe. So one of the things that was instrumental in happening was, number one, expanding the telemedicine code. So normally you have codes in behavioral health that you can utilize for video work, and we rapidly looked to expand those to some that were not included. The two that were not included were family therapy and group therapy, and we rapidly moved to have those as a part of the video technology that could be done. And then within just a matter of days, it was realized that that probably wasn't going to be enough this extreme time. And so partnered again to make sure that we were able to do the same services that you could do through video, you could also do those through telephone. So that was a rapid turnaround, something that was greatly needed. And one of the things that is very exciting is that we can see all the work that is going on out there in the provider community through video and telephone, and it's been tremendous. And that is for continuing to serve the people that have been part of our overall service group, and including also admitting new persons who have become very anxious or depressed or had symptoms reemerge due to these trying times. And the provider network, you guys have been amazing in really continuing to treat and serve people. I'll say a couple more things, but I don't want to hog Traylor's time either, so then I'll let him say whatever he likes. One of the things that people have reported is the wonderful ways that they're keeping staff safe as well, and that is through people who have kept a front door open where they have technology set up so that the clinician is in a separate room from the client, so the client can come in, sit down at the technology and work with the staff person in another room via technology that way. If they didn't have technology at home or they needed to get set up, that's been really a tremendous way. Also, for those of you that as part of your system do medication as well, being able to look ahead and kind of identify who's going to be having a medication appointment coming soon, and is that something that we can go ahead and get that script on an automatic renewal, make plenty of time for them to be able to pick that up so that there is no missing medication renewals. So overall, the system has just really, really stepped up and been very creative and done some really amazing things. Traylor?
Thanks, Carrie, for that. So yes, I am Traylor Raines, Deputy State Medicaid Director at the Healthcare Authority and Senior Care Operations. And I would second everything Carrie just said. When Mel and I were looking at some data earlier, behavioral health by far has exceeded the other provider groups in terms of utilization for telehealth and telephonic service, and we think that's a great thing. Again, because you're continuing to see your clients and you're adapting easily and quickly to this novel change. So I wanted to give technical highlights on billing. For those of you not accustomed to billing telehealth services, you will attach a GT modifier to that, along with your other modifiers to your relevant HCPCS and CPT codes. At this point, I believe we have all the codes added that are available through technology and telephonic, but I will say if you at any point reach a time where you're getting a denied code, reach out to our provider services department, and we will take a look at that and get it fixed for the entire system. I kind of wanted to give a brief update on additional flexibilities that are across the board for all provider types and our clients that we serve. The state did apply for an 1135 waiver through the Centers for Medicare and Medicaid Services. This was the first time that I know of that we've taken advantage of this flexibility, or had to take advantage of this flexibility, I should say. So we have some flexibilities that we've instituted across the board, one of which is we're not going to terminate anyone from Sooner Care enrollment during the emergency period. So we'd already made that decision as an agency and as a state, but then it's also a condition of one of the first federal legislation to come out in response to coronavirus, the Families First Coronavirus Response Act. Through that, state Medicaid agencies and programs are given a 6.2 enhanced FMAP rate that is geared and aimed at giving additional dollars from the federal government in order to respond quickly through budgets and additional services. For instance, one of which will be we see enhanced technological delivery of services. We also realize that in some provider groups that are serving those COVID-19 positive individuals, such as nursing facilities and hospitals, may also need additional reimbursement. So we're looking at flexibilities there and how we can use our enhanced match to better prop up our providers to services. So unless an individual leaves the state or chooses to be unenrolled for Medicaid, they will not lose their eligibility during the emergency period. Our online enrollment staff have ensured that anyone that was coming up for renewal will be pushed out. Right now we're saying 60 days, but if the emergency period continues beyond that time, we'll reevaluate and move it out further. As far as the telehealth flexibilities, we did originally say that those would extend through the end of April. But of course, as time nears, and we know that it's more and more likely the emergency period will extend, we will be putting out more global messages to providers to let them know about any extensions on the telehealth flexibilities. We also have questions about provider enrollment and screening. So we do have some wiggle room there. Currently when you apply to be a provider, there's the $500 application fee, along with you have to go through criminal background checks for all your rendering providers when you go through provider enrollment. We are waiving that now during the emergency period. So if you see a dire need for staff quickly, we're waiving the site visit, the background checks, and the $500 fee for new facilities coming on. Having said that though, once the emergency period is over, if you want to continue to be a Sooner Care provider, we will make you go through the regular processes in order to maintain and keep your contract going forward. Also of note, the federal agency in charge of enforcing HIPAA has waived enforcement of certain HIPAA requirements for technology devices. So for example, in the past couple of years, FaceTime has been deemed non-HIPAA compliant when in the past it was, but Apple hasn't signed a BAA with the federal agency in charge of enforcement for HIPAA. And so in recent years, they're not HIPAA compliant. But what the feds have said now is during the emergency period, whatever mode of communication you have to communicate with your clients and provide healthcare services, they will waive enforcement of HIPAA for those mobile technologies like non-healthcare Zoom, FaceTime, Skype, for example. Now, what they are not allowing is anything through a public platform. So you can't use Facebook, for example, to communicate with clients around healthcare issues. But the other face-to-face video technologies you can. I think that's the highlights. Mel or Carrie, can you think of anything that I'm leaving out?
Yeah, I had one question, and you and I actually haven't had a chance to visit about this ahead of time, so I apologize for that. But I do know as they are allowing some flexibility in terms of persons with licenses that in the past they allowed to lapse or those types of things, and to get some people back in the field to providing service. And I know they go through their board to get something that that says, yes, they are now can be active. Is there a means by which that process is been able to be a little bit expedited on the kind of the getting them enrolled as a provider with an agreement with an agency when that sort of thing does come up?
Sure. So what our provider enrollment staff would look at is whatever documentation the individual licensing board would provide to those individuals, and do that as a license, as well, if you would, for enrollment into our program. I know that Amy Brott, our Director of Provider Enrollment, also maintains communications with the licensing boards and the various paraprofessional certification boards as well. So we stay updated on any changes they're making, so we're sure to be aligned.
Very good.
Let's see, we have some questions coming in that we'll take. One is, will there be consideration of expanding telehealth following the emergency period, such as continuation of group and family via telehealth? I would say from the healthcare authority side, you know, through situations like this, we learn to be more innovative and in the approach that we take with providing healthcare. And so we will be monitoring the use of healthcare via technology and looking at client satisfaction, for example, and see if we're still getting the same level of outcomes that we would expect to see from face-to-face, with the understanding that a lot of these therapies still are more beneficial if you have the family in the room or your group participants in the room. And I'll defer to Carrie to follow up on that if she wishes, but we are looking at this across all of the Sooner Care programs to see if we should open up more to telehealth past just the emergency period.
I would agree with Traylor in that. I think we have seen lots of innovative and dynamic ways in which services and persons being served have kind of changed during these times. And I think we're all very much in favor at looking at those to see what worked, what didn't work so much, what is something maybe that should be continued, and what is something that maybe shouldn't. So I think we'll definitely be reviewing all of the changes that have taken place to see lessons learned from those, to see what works well and what doesn't.
So our next question is one that we've gotten several times before. So what about getting signatures for documents such as treatment plans or initial consents for telehealth clients during this time? I know initially that we were recommending snail mail to get these clients' signatures. I know a lot happens day by day, if not hour by hour. So Carrie, have y'all given further guidance around that, or are we still requiring snail mail signatures?
Well, one of the things that providers are doing, which I think works well, in that if the person has access to email, is to email them the documents. Then they can send back a confirmation email that they have read, understand, and agree with the attached documents. Then with further instruction to sign and mail those back in when they're able to, or perhaps when the time comes that they can come back in. But having that confirmation email attached to those documents feels good, feels comfortable, feels like everybody is in agreement. Then printing that out and putting it in the file.
So our next question is, if a provider is currently a candidate but will be licensed during the emergency period, will that person need to go ahead and apply for Medicaid provider enrollment as a licensed professional rather than a candidate? I would say this is the first time I've heard the question, but yes, go ahead and go through the normal process or the regular process of applying to be a fully licensed individual. This will allow you in an agency setting to receive a higher reimbursement. Right now, candidates are reimbursed at 10% less on average than a fully licensed. So that process would look as it does today. Although the healthcare authority and most, if not all of the DMH employees are commuting at this time, we've still been able to maintain our regular working processes. We're processing PAs as we have in the past. Provider enrollment has been successful in carrying on normal business as well as COVID-related business. Let's see, following sanctions to return back to work, will providers be penalized if they choose telehealth for another month? I'm not sure about the question, but we are allowing telehealth, as I mentioned earlier, right now through the end of 30th, but we are looking at extending that if the emergency period extends.
I think the question, I may be misinterpreting it completely, but may be related to kind of personnel policies and employer policies. And if so, those would be something to discuss with your HR department where you work. But Taylor's correct in terms of your billing and doing telemedicine, then that's something that we'll continue to look at as long as the need is there.
The next one was the GT code for adult family therapy. So yes, GT modifier has been added to all of the HCPCS and CPT codes where they didn't previously exist. So that would include family therapy. Question, right now, individually contracted providers can see children but cannot see adults unless they work through an agency. Will this change that we can see adults without working for an outpatient agency? We'll say at this time, that is not one of the flexibilities we've been given. That's a state plan coverage requirement currently in the Medicaid state plan and was not an option to expand services through the 1135 as requested. We can evaluate that on an ongoing basis, but at this time, that decision has not been made. Question about, can you use Facebook video chat? My understanding is that anything related to Facebook is not an acceptable form of telehealth at this moment, and it's one that the federal agency regarding in charge of HIPAA oversight would still find that as an error. Do you know if Medicare also allows just telephone without video? I don't think that they do. I know that CMS has put out a lot of guidance at cms.gov related to Medicare requirements. They have expanded telehealth to an extent, but I'm honestly not sure. We can look that up. And I will reiterate that all the questions coming in, we will respond in writing and put on our public site. It's okhca.org/COVID-19. As well as we are videoing today's session, and we'll post that within the next day as well. Can a psychiatrist build their usual E&M codes if patient can only use phone? Good question. We have, if you go to our global update section of the OKHCA website, under the provider tab, there's a link that says updates, and we can follow up with that exact link. But we have opened E&M telephonic codes for physicians. So psychiatrists would follow the physician billing guidelines, and we have specific telephone codes for them, not your regular E&M visits.
There's actually been quite a bit of that going on out there.
As an Indian health facility, we use flat rate coding for office visits. We will continue to use the coding, or do we have new flat rate codes for the telehealth visit? Thank you for this question, and it's going to be a plug. We are having a specific provider webinar to answer these questions specific to our Indian health providers on Friday at 11. So I encourage you to sign up for that one as well. But on this one, I would say that you would bill your OMB rate as is, including for the telehealth visit. I heard you mention that group is approved via telehealth. Can you provide the billing code for this? That's a good test of my memory. I know it starts with H0004, and there's another modifier in there. We can get that to you if Carrie doesn't know it off the top of her head.
I do not. I said, I'll ask Trailer.
Crystal or Mary Ann, do you know off the top of your head what the modifier combo is for group?
Yes.
Yes, I do.
Yes. H0004HE HQ, then add the GT, please.
Excellent.
Thank you. Let's see, there's a broadcast message on the OHCA website stating that OHCA has opened all senior care reimbursable codes to telehealth using GT. The only specific services that have been addressed are the family and group therapy. What about case management? We are receiving denials when billing the GT modifier. That's a good point, and I've tried to reiterate when we get the message out that the right answer is most. We have opened most, but I still think case management should be paid for by GT though, so we'll look at that. I'll also defer, Crystal or Mary Ann, have you seen those denials or?
Yes, sir. So case management services and screening services have been approved for over the phone delivery. So we have not added on the GT modifier for those particular services.
Okay, so just go ahead and bill them without the modifier, because currently you can do it without. That's what I'm hearing? Check the answer tab, and there may be an answer there. See, if adequate data can be obtained, can psychological testing occur via telehealth during this time, and is GT code required? I get referrals from child welfare to determine if their child qualifies for developmental disability services. We have had this question, and I will say that the Oklahoma Psychological Association has posted a lot of good resources on their page about being able to deliver these services via telehealth. I also believe, and Carrie, Mary, and Crystal, correct me if I'm wrong, I do believe we are in the process, if we haven't already, in adding the GT modifier to some of the testing codes.
Mm-hmm.
The testing codes have the GT modifier added now.
Great, thank you. So there's a question: if some clients still prefer face-to-face, does it mean the provider cannot see them face-to-face? I would kind of tack on to what Carrie mentioned earlier regarding each individual facility and employer will have their own policies around safety during the emergency period, and we would defer, if you want to see someone face-to-face, we would refer to CDC guidelines, the governor's orders, any local orders granted by mayors in your municipalities, just to see if you would fit with any of those and if the client is comfortable and safe. Let's see, did you say that family telehealth was okay or only individual? Yes, family and group, in addition to the currently covered services by telehealth, such as individual, are covered during the emergency period. There's a question on, can candidates provide telehealth services? I do remember some initial conversations around this. I want to say yes.
I can help with that a little bit. So in terms of our policies and guidelines, and when I say our Department of Mental Health and Healthcare Authority, yes, they could. There had been something that was kind of blocking that, though, and that happened, I know, on the LPC licensure rules, and that it required that your on-site supervisor be with you on site. Well, when someone under supervision was doing telemedicine from home, they did not have an on-site supervisor, if you will. So that was kind of a caveat that was throwing that off. The licensure board met a couple of weeks ago, and on their page is a document that shows what they have deferred during this time. And so it has waived that to allow those that are under supervision to be able to do that, even if it's from a home setting where their on-site supervisor would not be. So long answer to say yes.
And I'm adding on that, I think there's been some interpretation from Sooner Care telehealth policy in the past. It currently says certified or licensed individuals can provide telehealth services. I know at least during the emergency period, we will allow a candidate Sooner Care reimbursement for telehealth services. Let's see. Does telehealth expansion include Intra-Oklahoma? It does for the Intra-Oklahoma individual plan, which is directly administered by the Healthcare Authority. See, what if the family doesn't have access to email via computer to obtain signature? Carrie, correct me if I'm wrong, is that a snail mail situation?
Then you would go to the straight snail mail situation.
And we'll reiterate there too, we understand there's some fears around touching paper, that maybe we don't know that source, and that we know that COVID can live on objects for a certain amount of time. You don't necessarily have to open that right away. So this would come into play. Of course, we want to know that consent was obtained, but this would really come into play during a healthcare authority or DMH audit. So as long as, if you don't feel comfortable opening immediately, set it aside for several days and open it at a later time and add it to the individual's chart.
And I would document in my note that that you receive verbal consent from the client.
Let's see. So there is someone that said, yes, CMS is allowing care and phone services for rural, non-rural. Good, thank you.
That's what I thought. But I did like the part of let's find that document so we can put it out there. But
Yeah.
I'd heard that CMS had just opened a bunch of codes for telephone.
Good. So there's also a comment that hhs.gov has stated that Facebook Messenger is allowed, just not Facebook Live. And is that correct? Again, we'll have to follow up with that. I believe what you're saying to be true, but everything's changing so quickly that we're having a hard time keeping up. Let's see, during this time, have they increased the amount of hours we can bill, as we were limited to 35? As of right now, we've not increased the number of hours that can be provided. Now, we'll remind everyone that exempted from the hour requirement is crisis. And so if you have reached your 35 hours from your individual, family, group therapy, and one of your clients is in a heightened anxiety state or needs a crisis visit, you can use 2011 and it'll pay outside the 35 hours.
And also, if I remember, assessment was not part of that 35 either, correct?
That's correct. Let's see, what is the HCPC for case management billing? We have two. I know this one. T1016 is intensive case management and T1017 is regular case management. Let's see, what about recovery support specialist services? Can they provide services by telehealth and with a GT? The answer to that is yes. And actually that has been covered traditionally by Sooner Care with a GT modifier. So that's not new.
And a lot of really good peer work going on out there during these times.
Mm-hmm.
Let's see, would a letter of termination be acceptable to follow the same guidelines via an email? Have the client respond to email and send to DMH? My understanding is the letter of termination collaboration process, if that's what you're asking about when you're sharing services with another agency, that would still be performed electronically in the PISA system like it's currently done.
Mm-hmm.
And I don't think, we can verify though, but I don't think that requires client input in the PISA system. Let's see. There's a long one, but let's see. OHTA has stated the following would be acceptable means for obtaining consents and signatures. This sounds different than from what was just stated. Please advise. Okay, this is fun. Signatures for treatment plans and other service documents can be obtained by postal mail with a return envelope or returned by email, electronic signature or fax signature. If those methods are not achievable, providers may consider the options below. However, providers should ensure the accrediting entities also accept these methods. Robust documentation is kept and internal policies are addressed. Email the document and client emails back a written consent, not able to print, sign, or scan. Record a statement and keep recording. Document a statement along with reasons this method was necessary. Use voice signature technology. I think that's pretty much what we just covered. And so maybe this question was asked before we gave the additional follow-up, but I think that's what Commissioner just mentioned. Can telehealth only be billed in 30-minute increments? So the GT modifier doesn't change any way you provide or bill the service, except that you would bill as usual. You just attach the GT to your regular claim. So right now, a lot of our HCPC codes are in 15-minute increments. And so if you bill an hour of H0004 for therapy, you would just bill 4 units of H0004 and add the modifier. Let's see, if a clinician is under supervision and hasn't taken her NCE test, is the testing going to be waived for a time period? So we can't speak to that. I would say you need to reach out to your individual licensing board as they are also updating their policies around the emergency period. Are the telemedicine modifiers available for initial mental health assessment? Yes, they are. For the LVP who only have 4 units per month, are you increasing the unit numbers for the members to be seen more than 4 units per month? At this time, we have not increased any billing limits across any provider type. How can you provide psychological testing via telehealth since the test battery has to be administered in person? I would defer to also on that to your licensing board. Like I said, the Oklahoma Psychological and the American Psychological Association have put out a lot of good guidance on how to adapt to these times where we need to use telehealth.
And and within that, there may be some types of testing that does lend itself to tele and some that does not.
Right. Do we use the O2 place of service along with the GT modifier? I'm going to look at Melody for a thumbs up or down, but I don't think we've ever required the O2 place of service for telehealth. So it could be home or office. Is that correct?
Yes,
Okay.
that is correct. But we can clarify. I believe our system will take either, but we prefer the GT.
So our system edits based off of GT and not the place of service. So it would be information for us, but it wouldn't affect your claim.
Right.
Is rehab services allowed via telehealth? It is, as well as telephone during the emergency period. Let's see, can patients out of state be seen via telehealth? Are there any restrictions? I would have to defer to the policy for the state in which the client lives. So our Sooner Care policy is around residents of Oklahoma. And we can only set policies for our program within our state. I will say that a lot of states are waiving licensure requirements during the emergency period for in-state licensure. If you are licensed somewhere, I would always defer to that other state program on that. Let's see, is DocuSign an acceptable format for signatures for client and providers? I have not seen anything related to guidance around DocuSign. I don't know if it's HIPAA compliant or if that's stored in the cloud that's not secure. Carrie or Melody, have y'all heard anything?
I am not familiar with that specifically.
No, me either.
That would be good for us to look at, though. I'm going to punt that to Marianne and Crystal to research after this. A question from my friend Joy. So even if we get a verbal consent now, we will be a snail mail and add to chart when we get a return. That's correct. And when consent, for us, that's consent to tweet. And so we did away with requiring a separate telehealth consent in state statute a couple of years ago. So you don't have to have a separate consent just to provide a service like telehealth. Now, having said that, we do require currently in rules that a parent present a child or a minor for a telehealth session, but that can be an in-person presentation, that can be you calling parent or guardian or getting a text message, just something that you've noted in your chart that parent presented the child. It doesn't have to be face-to-face. Let's see, how about driving by and dropping off the treatment plan, et cetera, in the mailbox and then picking it back up? I say whatever means you want to use to get that signature, I think that's great. As long as you're following all of our governor's executive orders, CDC guidelines, and local municipalities around stay-at-home orders. Let's see. Can we split up the units per week? Example, 4 30-minute sessions instead of 2 one-hour sessions? Absolutely. I would say, and I think everyone would agree, whatever is in the best interest of the client. And if the client is amenable to receiving their services in that way, we are absolutely okay with that. For case management, are you saying that we can only do it by telephone and not telehealth? No, we're not saying that. I think we just didn't set the code up to allow for GT. Say just kind of an overarching though is during this emergency time, we want our providers to do whatever you need to do to best take care of our members and your clients during this time. And in return, we'll do our best to make sure you're taken care of and that you get reimbursed for services provided. So go ahead and provide the service you need to and bill it. And if you encounter a denial for any reason, we'll definitely look into that and see what we can do to fix it. Okay, let's see. Leslie Earl said DocuSign is HIPAA compliant. So I will take your word on that. And if folks want to use DocuSign, we will also do some research internally just so we can distribute it to other provider groups. Let's see. PDF filler is also HIPAA compliant, is what one commenter said.
I do think that there are a number of different HIPAA compliant that you can utilize for e-signature. We obviously wouldn't have an exhausted list of those, but it is nice as you send those, as Traylor said, we can verify and then put it in the document of this for others to be able to refer to if they want to use them.
I did receive a question too. I asked a question, but it's no longer showing on the screen. So some are showing up under the answer tab if it's been answered. Some also, if they've been asked in the chat box rather than the Q&A box, we're not monitoring the chat box, so please direct your questions to the Q&A box. So you did correctly that existing clients don't have to sign consent for teletherapy. Does it only apply to new clients? no, you are correct. That was a state statute that got rid of the telehealth consent a couple of years ago. I understand that some providers continue to do that, and that's their own practice, and that's fine, but it's not a requirement at the state level or the healthcare authority level. Let's see. Was we able to, I lost it. Okay, able to list a few examples of HIPAA compliant documentation signature software that the state approves. So I will say probably not. So currently, even in our telehealth world, we don't recommend even certain platforms for video technology. We will ask that the provider do their due diligence in researching the right platform that is HIPAA compliant, and that would stand for any signature platform as well. Will we have to verify that these electronic signature platforms also meet our accrediting body requirements as well? Yes, absolutely. So anything that Commissioner and Melody and I are mentioning today only applies to state level reimbursement and statutes. So we would always defer to your licensing, accrediting, and certification body to also ensure that anything we're talking about meets those requirements as well. We're trying on our side to make sure that it's all aligning, but as I said, things are moving so quickly, we want you to be able to verify on your own as well. Okay, can you clarify the requirement regarding a parent presenting the client? For example, a child joining group rehab via telehealth, would we have to see the parent prior to providing the service, or is overall, meaning one-time initial consent from parents for services via telemedicine adequate? So right now in rules, you need to be able to note in the client's chart that the parent or guardian presented the child for that telehealth session. The parent does not have to be physically present. So you could call the parent, text the parent for that individual session. Now, having said that, we are in the rulemaking process. So when permanent rules go into effect in September, early October, that requirement is no longer there. So we will just want something, and I will defer to rules and we can give a link to that afterwards. But we will, and after 9/1, we will want to see something that shows that the parent understands that telehealth will be a way that services will be provided, but we won't have the presentation requirement. But for now, they don't have to be physically present, but you do need to know that, yes, they knew about this session either through a phone call or text. Okay, another commenter said doxy.me is HIPAA compliant and very easy for patient to use. And I'll reiterate, unless you don't, feel free to not have to take a lot of notes during the call. We are recording it and we'll post it to our website as well as the written pieces, written Q&A, so that you can go back and reference all of these. Let's see, in the past, if we build one 4-unit H0004 code and two 2-unit H0004 codes in 1 week, the third claim would be denied. Has this changed? So it would only deny if you reached your 2-hour max that is cumulative between individual and family. So we do have a 2-hour a week max for IT and FT. So that last unit would get recouped if it went over that 2 hours. If I didn't answer that question, we can clarify and do our best. Unless Crystal or Mary, am I missing something on that question?
Hi, this is Mary Ann. Can you hear me?
Yeah.
Okay, sorry about that. So for your individual and family, they have a daily max of 4 units, which is equal to 1 hour per day. And the cumulative of the family and individual for 8 units or 2 hours within a cumulative week, just a calendar week. So if you go beyond 4 units or 1 hour a day, of course that claim will deny. Or if you go beyond, and it depends on the specific modifier that you use. So if it's the individual psychotherapy modifier, or if it's the family modifier, both of those, of course, they'll pay, but once you hit that 8-unit max, it denies.
Thank you. Let's see. Okay, I said I wasn't going to do this, but we've run out of questions in Q&A, so I'm going over to the chat box. Let's see. What is the reimbursement for the E&M telephone codes? Are they comparable to regular physician? That I'm not sure, but I would direct you to Mel. I'm guessing those codes have been added to our Title 19 fee schedule on our
They should have been, yes.
website.
And we can always post it in a response to that question.
So Marianne, I see I have always billed 1 hour individual and 1 hour individual on the same day. Are you saying we can't do that?
It is the same member, there is a system max of 4 units per day.
Mhm.
So if you bill 8 units for the same member, then 4 units for 1 hour denied.
Okay. I'm not sure if they also meant FT on that one, but yeah, she meant
Right.
So they
Yeah, because
billed
there's
1 hour.
specific,
Go ahead.
sorry, there are specific modifiers. Individual psychotherapy is H0004. Mental health use first place modifier of HE.
Same day. You just can't build more than 2 hours in a week.
Correct.
Okay. So I'm seeing just a lot of general billing questions that seem to be outside of the emergency period allowances. Marianne, do you want to give the email address that these would normally be sent to for behavioral health billing questions?
Well, typically, if there's behavioral health specific, I usually just give out my direct line and my direct email. And then also Crystal Hooper is my colleague who assists me with all those. But you can also call the call tree number, and they usually will be able to answer the question if you get to provider services. But if they cannot, I'm more than welcome. I will give out my direct line, and you guys directly, and Crystal will be happy to do the same.
Thank you. Let's see. So a couple of questions around telehealth codes. So I will say for the behavioral health code set, all the codes remain the same, whether you're a HCPC code or a CPT code. The only thing you do differently is add a GT modifier if you're providing it by telehealth or telephone.
With the exception, we were reminded today of case management, which doesn't need a GT code.
Good point.
Right.
So where on the website do we find the billing schedule for private practitioners? So that would be okhca.org/behavioral-health. So all the behavioral health resources are there, including all of our various fee schedules for our behavioral health practitioners. See, is there any consideration for allowing therapists in private practice to provide family and individual therapy in a week during this time when family stressors and involvements are higher, or possibly adding allowable time so that we can provide a family treatment in addition to the 4 hours a month currently allowed, so they are not faced with taking one individual hour away from a minor client to see parent for family session. I would, again, we will definitely take it under consideration and look at that and see what we can do. As of right now, we have not looked at expanding any current limits as authorized in rules or your prior authorization. So repeating the website information, and I'll type it out here so everyone can have it, but it's www.okhca.org/behavioral-health. And also, I know that the Department of Mental Health and Substance Abuse Services has added a lot of related information to their page as well. Carrie, do you want to mention that one?
Yes, we have a couple of different things on our webpage, which is odmhsas.org. We'll also, if you'll share these frequently asked questions, we'll add them to ours on that site. We have a frequently asked questions page there that has some of the information that we've gone over today, and then some additional things outside of that, just things that providers have asked. And when they ask, then we go ahead and post it. Others can see the answer. We also have a resources page on there that is helpful for yourself and for your the persons that you're serving, that has information about ways they can and support groups of all types over the internet, via Zoom, different types of chat groups and text groups that they can do to help continue to move them forward in recovery during these times when they're spending a lot more time at home.
All right, well, we've not received any other questions, and so I think we, again, thank you for your participation today. This is so far our largest turnout, which is very exciting. I wanted to reiterate from all of us too that we see you, we see the good work you're doing out there with your clients and our members, and you are appreciated. And please let us know if there's anything that we can do to help you fulfill those services, and we'll do our best to do that. And I will kick it back to Melody and or Carrie to help finish this up here.
Well, I would just say I would echo Trailer's sentiments that the work that is going on out throughout the state is just amazing. Prior to this, I would put our behavioral health system up against any state, but I think that we have just shown leaps and bounds above other states in that what we can do, how quickly we can respond, how quickly we can adapt, and how we can continue to serve those needs. So I just want to send a special thank you to each and every one of you for the work that you're doing.
And I also want to thank everyone for participating today and for all you do for our population. Please know that we are there with you 100%. If you need us to have another Zoom meeting as things progress, please reach out and we would be more than happy to get the three of us back together. And we will all get through this together. So thank you so much for everything you do.